So therapies are exciting. And the reason why it's exciting is because imaging is serving as that bridge from diagnostics to therapies. So I'm not going to go into all the minutiae about therapies because it's Sunday morning and we're all, but we're going to focus about the role of the urologist in all this and how I think there's an opportunity for urologists to play a really big role in the future of how this all sort of takes place. So we're going to talk about 2 trials. We're going to talk about changing disease states trials and opportunities for urologists. So we talked about this earlier. Again, we just change this isotope to something like lutetium or actinium. All of a sudden, it becomes a missile. It could start killing cancer cells as opposed to just showing us where they are. And that's what this shows, courtesy of Dr. Morris. And this is something that is just really tells a compelling story about how it's really helped out a lot of patients, which has been now proven in large phase 3 trials. So this is the VISION trial presented in ASCO, I think, almost 2 years ago. Open label study, randomized in a 2-to-1 ratio of lutetium PSMA 617 versus standard of care alone. And it used PSMA as one of the inclusion criteria to get into the study. So you needed PSMA positive lesions in order to qualify. And this was patients who were treated with at least one androgen receptor pathway inhibitor and at least one taxane prior to this. So very late stage patients who then went on to get lutetium PSMA 617. And the overall survival was positive, hazard ratio 0.62. Again, these were really, really sick patients who then all of a sudden we saw this improvement in overall survival, which is very important. And that's why there's been so much excitement about this. And I have no doubt, radiographic progression-free survival, again, much better in those who received the drug versus those who did not. So this was very exciting, obviously led to the label and the FDA approval of lutetium 617. Obviously, supply issues are a different issue right now, but I think it gives us all an opportunity to start, getting our programs ready for when they are back online. So, lutetium PSMA versus cabazitaxel. This was a phase 2 trial from Dr. Hoffman in Australia that compared this versus cabazitaxel to help us give some better understanding of how we might sequence these drugs. And what it showed was that PSA response, greater than 50% PSA response, was better in those who received the lutetium versus cabazitaxel. And what was really interesting about this study is it used multiple different imaging tools to help pick the patients better. So if a patient was PSMA negative, their metastatic lesions were PSMA negative and FDG positive, they were ineligible, which makes sense. Because if the diagnostic tool doesn't show PSMA positivity, why would you want to target that with a PSMA targeting agent? So again, they weren't eligible. These were PSMA positive, but they also had FDG positive and PSMA negative lesions. So those weren't included, those patients. But if you were PSMA positive and FDG negative, you were included, which is probably the best patient population. But even if you were FDG positive and PSMA positive, again, because you were PSMA positive, you were eligible for this study. So it really tried to pick out those patients who had more PSMA positivity to undergo this treatment. And the data that they're reporting shows some improved quality of life with PSMA 617 versus cabazitaxel. They're also showing that a high PSMA uptake shows a better response, which kind of makes sense. If you're sucking up that PSMA more, you're getting more of the radioactivity, more of the radiation, more of the kill of the prostate cancer cells. So hopefully you should get a better response there as well. And then if you were higher FDG positive, that indicated a poor prognosis, which makes sense too, because FDG positivity usually means more aggressiveness, and that's maybe why they didn't do as well. And their conclusion was that it's a suitable option. It actually had similar overall survival based on their three-year data, but maybe some of the other endpoints are showing that it could be used before cabazitaxel. This was a recent press release from Novartis that showed that their phase 3 trial called PSMA-4, looking at that same drug but using it before chemotherapy, so CRPC pre-chemotherapy, met their primary endpoint of radiographic progression-free survival. So we're awaiting these results. Hopefully, supply gets back and we have an expanded label and maybe we can increase our access to this for our patients. Though I'm hearing some chatter about, RPFS as an endpoint and whether that will be accepted, but We'll know more about that in the next few months, hopefully. This is just for informational purposes. People are looking at this drug in trials in very interesting spaces. So this is called the lutectomy trial, looking at this prior to prostatectomy. So kind of like this neoadjuvant type of therapy, which very interesting. So, and then if you go into clinicaltrials.gov and you look at multiple combinations, you're seeing that this drug, the companies are investing this in multiple different spaces. Combination with docetaxel versus docetaxel, LuPARP, so lutetium-617 plus a PARP inhibitor, immunotherapy plus this. So a lot of different areas in which this drug is being studied. And again, I think what we're going to see is, obviously it starts sort of in that later stage and it's going to creep up potentially all the way up to patients before prostatectomy, which, at first I kind of laughed, but, maybe it does. Maybe it helps clean up a lot of those, small disease cells that are out there in the system. This just shows that there's a huge potential for growth in this area, and this is the projected market for a lot of these different therapies in the future, which I think sends a strong signal about where the field in general is moving. So the role of the urologist. Get comfortable using PSMA PET-CT. I think that's an absolute must-do. It's important for your patients, in those various disease states. And again, it's going to be important for therapies as well. And it's important because you guys manage a lot of these prostate cancer patients and advanced prostate cancer patients. And I think it's important to get comfortable with the whole ordering process, the interpretation process, and how you use those results. And our RaDaR 7 article actually helps physicians understand how to manage the results from a PSMA PET. Advanced prostate cancer clinics, I think, are amazing. They're wonderful. And, there's a current status on how they work, but there's a future state. And it's nice to see a lot of these urology groups sort of take advantage of this and figure out who their authorized users are, how they operate, make this operational. And then education, professional education and patient education, because the patients are going to come to you with questions, and it's important that you know how to answer them.